So I'm going to talk about new pathways for chronic insomnia, sleeping pills versus sleeping tests. The simplest definition of insomnia involves having difficulty staying asleep, difficulty falling asleep greater than 30 minutes. Complaints of waking impairment is critical. The fact that you have daytime impairment from not sleeping well, that gives the diagnosis. Usually we expect the patient to have the problem for 3 to 6 months, but more likely we will see patients who've had these conditions for years. And then poor sleep quality or non-restorative sleep is incredibly common in patients who have insomnia. So what is the way these patients treat themselves? Generally, no treatment. Most people with insomnia do not treat themselves. They don't even necessarily think that there's something they could do about the problem. If they're going to use a treatment, one of the most common, arguably the most common, is self-medicating with alcohol. In addition, many people go to drugstores and get over-the-counter medications. And then a smaller proportion, but still quite sizable, get medications, prescription sedatives through their physicians, including sedating agents, not just sleeping pills, such as antidepressants. The problem with these treatment approaches in general is that the insomnia patient often is not educated to look beyond the dimension of sleep quantity. So insomnia patients think it's the number of hours they're supposed to sleep is somehow the target, the goal for how they're supposed to look at it. And they tend to be ignorant of or unable or uninterested in evaluating the quality of their sleep, which is really where the action is. And that's why you get a ceiling effect, which simply means that when the insomnia patient has received a treatment and has received some improvement in the treatment, they then normalize that level of success, whatever it happens to be, and they think that that's it. They don't believe there's something that goes above that, unless, of course, they're either astute and can observe that it's not quite as good as it should be, or they're just continue to complain because they're not getting good sleep. Many of those treatments do not work very well over the long term. They may be useful in the short term. So the question at hand is, can somebody with chronic insomnia achieve a normal state of sleep or an optimal response, which would mean falling asleep rapidly and staying asleep, sleeping all through the night, sleeping as long as needed, feeling refreshed and restored in the morning, and doing this night after night. So can an insomniac actually reach this state? Can they? Is that possible? And the answer is yes. The more we've learned about insomnia, now we know that this is possible. Where do we look for this cure? Well, a lot of research and a lot of evidence and a lot of attention is given to the mind and not necessarily the body. We tend to look at both. If you look at most current paradigms, people are talking about the psychological or the psychophysiological or the neurobiological approach to insomnia. And that's how you end up believing that a sedative is a good treatment or an excellent treatment for insomnia, when in fact it's not. Much better treatments are usually cognitive behavioral therapy if we're going to be thinking about psychological treatments. In our own work, we've learned that if you look at the emotional system of the patient, or actually the spiritual system of the patient, and certainly the whole human being, we get a lot more success and we come much closer to the cure or the normalization of the individual's sleep. So if we wanted to ask some insomniacs why they have insomnia, we would want to start with allegedly typical insomniacs, which would be women, middle-aged. They suffer moderate to severe insomnia. They use hypnotics nightly. They have a past mental health history or current mental health history of anxiety and depression, possibly post-traumatic stress. And notice the last 3 points. They should not have obesity or sleepiness or breathing symptoms. So those would be so-called typical presentations for insomnia. I'll just say again that that's not accurate. This is actually a classic form of insomnia, but you're going to discover very soon here it's not typical at all. But for now, before I explain more about this particular study, I just want to show one slide of the 20 individuals that we were able to recruit who fit this category of classic insomnia. And notice when you ask them the question, why do you have difficulty falling asleep at night? And why do you have difficulty staying asleep at night? You get the following answers. most of which you can see are all related to mental health issues, specifically the inability to turn off the mind, which is clearly the single greatest pronouncement by people who walk in the door to a doctor saying, I can't turn off my mind. I've got racing thoughts. I've got ruminations. I've got worries. If you could just get me to turn off my mind, I could go to sleep. And that's how you have this connection that would say, well, a sleeping pill should be a good technique to turn off the mind. And that's how you end up with that, what I'll call very narrow, limited differential diagnosis that ends up with getting a certain proportion of patients on sleeping pills. Sleeping pills don't work for a lot of people. A lot of people try sleeping pills and then they stop using them. So what I want to do to counter this idea of the typical presentation is show you some presentations that occur for sleep centers and for primary care. This first one, you'll see at the top, there were 4,355 patients who presented to our sleep center, of which 1,000 ranked insomnia as their worst problem. Okay? So that's a lot of people saying, this is the reason I came to your sleep center, because I have a severe case of insomnia and I want help for it. So here's a close-up to make it easier to observe. So this is the group, 1,000. We swing back here, we call them group A. But look what happens when we continue looking at their information that they provided to us on intake. What we see is SDB stands for sleep disordered breathing. So there's 1,000 patients walked in the door and said they have insomnia, and that's what they want help with. But 40% of those 1,000 said, oh, but I also have a sleep breathing disorder. So they're actually ranking it with the knowledge of they think they have a disorder of breathing, but they're not connecting the two, the insomnia or the sleep disordered breathing. Let's go to the next one. Another 13% have sleep disordered breathing attributes. Things like, you know, I'd like to get rid of my snoring. Or sometimes when I wake up at night, I notice I'm having trouble breathing. Well, those things should be suspicious for sleep disordered breathing, but it doesn't mean you have a sleep breathing disorder. Nonetheless, it's a breathing-related phenomena. 13% of the sample also has that. Now we come to the bottom, and we look at people who actually have sleep breathing symptoms. They may have snoring, loud snoring, choking, gasping, witnessed apneas. They may say they have other trouble breathing at night, but they don't think they have a sleep breathing disorder, yet they've got all these symptoms. All is said and done, you have 197 people, or only 19% of people who walked in the door of a sleep center saying, I've got an insomnia problem. Only 19% of those people have nothing to do with breathing, according to them. As it turns out, you'll see something to do with breathing is still present in even many of these individuals. So to summarize, 81% reported some sleep breathing symptoms, 40% recognized a disorder, and virtually none of these people walk in the door thinking, I wonder if these two things are connected. Most people, in fact, would still continue to think about stress, anxiety, depression, worry about sleep, even the phrase, I don't know. They don't know why they have insomnia. And then, of course, there's some very important comorbidity factors such as pain, cancer, and nocturia. Now, obviously, there's a lot of skew in a sleep center, because if somebody is going to a sleep center, clearly they're going to have a higher potential or referral potential for somebody to say, well, maybe they got sleep apnea. So what does this look like in primary care? We did a study that was recently published, a 2.5-year study that involved 10 primary care practices in Albuquerque. The patients were coming in and evaluated in the waiting room, and they only were eligible if they didn't have a sleep complaint. So they're coming for everything else. They're coming for blood pressure, diabetes, obesity, whatever it is they're coming for. It can't be sleep to be included in this study. So we surveyed them with a brief survey in the waiting room. We had a 65% response rate. And again, sorry for the huge slide here, but we're just going to look at the top part. Again, we get 1,000 people in this study, and what do you see already? Over here, we had to eliminate 236 people because when they walked in, they already were diagnosed with sleep disorders. They had insomnia, they had sleep disordered breathing, whatever they had. We didn't want to see that. We wanted to see the people who had no past history having anything to do with sleep and were not seeking care for a sleep problem. So now we have 801 people, and of those 801 people, what we see is that if you use the Insomnia Severity Index score, which is a very well-validated scale, greater than 7, that is consistent with an insomnia disorder of mild, moderate, or greater severity if the person reports the daytime impairment. The insomnia patient has to report the daytime impairment for it to be a diagnosis. So here you have the close-up. On the top bar, you see you have 171 mild, 92 moderate, and 26 severe insomniacs. So this is 289 people with some form of insomnia. Well, then on the second part of the survey, we looked at their breathing symptoms. And what did we find? That many of them reported at least 2 breathing symptoms, or they reported unique breathing symptoms, such as, I have had somebody tell me that I stopped breathing at night. If somebody tells you that, your chances of having sleep apnea are up around 90 to 95%. With those numbers done in either way, you can see that 90 people out of the 289, 30%, have a very, very high probability of having sleep disordered breathing. Notice this very interesting slide that the number of breathing symptoms you have, snoring, loud snoring, choking, gasping, witnessed apneas, other trouble breathing at night, the number of breathing symptoms you have correlates with how high your insomnia score is. So you can see where I'm going with this. To summarize, 51% of the patients had 1 insomnia or 1 sleep disorder breathing symptom. SDB correlated with insomnia. We mentioned 91 or 31% had the diagnosis. But what you now need to hear, and I'll explain this later in the talk, this is a gross underestimation of the number of people who really have sleep disorder breathing. And that's because sleep breathing symptoms are incredibly unreliable in trying to pick who needs to get a sleep study. Why is that? For the obvious reason. People don't know what their breathing symptoms are, or people lie or are embarrassed to talk about their breathing symptoms. So that number was small compared to what we found at the Sleep Center, but it was artificially small, as you'll see from what we go through next. We had some excellent commentary in this journal about it from Nancy Collop, who is a past president of the American Academy of Sleep Medicine, who summarizes this beautifully. I don't sleep because I can't breathe. We must encourage our colleagues in primary care and other specialties to think about sleep apnea as a potential cause for the patient's insomnia complaint. Unless the physician is thinking about sleep apnea as part of the differential diagnosis in a patient with a report of insomnia, a sleep study is unlikely to be ordered. So let's talk about breathing and see why it would cause insomnia and also be clear about it. This is normal breathing, somebody actually who's using PAP therapy. And we talk about rounding the curve. This is the rounded inspiratory curve. This is the rounded expiratory. This is obviously something quite wrong. This is somebody who's got a flat line and is not breathing. And notice also that in this section of the slide, it's less dense than this section. So what is it that happened right here? Any guesses? Why is the EEG more dense after the breathing event? Patient woke up. So the brain waves sped up. The person starts to breathe again and then goes right back to sleep and has another apnea. And that's how sleep breathing problems were first described in 1973 by the world's greatest living sleep researcher then and now, that there was a connection between sleep disordered breathing and insomnia. And this, of course, is the obvious connection. You can see it again here. This is a hypopnea. It's about a 50% reduction in breathing. And again, you see the arousal activity occurring after the breathing event. If that arousal activity extends for several minutes, the patient is going to wake up. And then they're going to start to have racing thoughts and ruminations, and they can't get back to sleep. Here's a close-up of the hypopnea. Again, a 50% reduction. And let me just ask, how many of you are familiar with either looking at a sleep study report or having a discussion about a sleep study report where they talk about the apnea-hypopnea index? Just raise your hand if you're aware of that. Okay, so that's the general metric that's used. but that metric is actually out of date. There's a third component that's supposed to be included with the apnea-hypopnea metric, and that's called upper airway resistance. And it's extremely common among insomnia patients. It's a much more subtle form of breathing that I'll show you in a moment. It's largely ignored by many in medicine. Even sleep physicians may ignore it. And yet it is a very treatable condition, and the improvement when you treat the UARS will actually lead to part of the program that you need to do to cure the patient of their insomnia. Now these next two slides are very critical to appreciate how sleep breathing is often misunderstood. You can see that compared to the apneas and hypopnea, we just really have the top of the curve that was cut off. Everybody see that on these slides? And you'll see just above it, there's snoring, all right? What do you see on the next slide? The airflow curve is cut off, but there's no snoring. So you can have the diagnosis of sleep disordered breathing without snoring. In fact, snoring is the single most misleading piece of information that you can get in trying to understand whether or not you want to send somebody to a sleep center for evaluation. Virtually sizable numbers of patients come to a sleep lab and never show snoring whatsoever. So if you ask people about snoring, there's only one snoring question that's ever of value: do you snore loudly? If you snore loudly, that's a very high probability for sleep apnea. But if you don't ask that question, if you just ask about snoring, you'll get so many no's, you'll end up with an enormous number of false negatives. Here's another close-up of the UARS showing the cutoff of the very top. And again, you can see the darkening of the EEG showing that the patient has awakened or aroused. So in 2001, we published the first paper that used what's called advanced respiratory technology, nasal cannula pressure transducer, on a group of individuals that had insomnia and nightmares. These were crime victims suffering from post-traumatic stress. We had offered them cognitive behavioral therapy and other treatments that we do for nightmares. But at this time, actually, 5-6 years before that, we had begun seeing this trend where many people with nightmares and many people with mental health problems have covert sleep apnea. And because they have so much presentation focused on their psychiatric illness, people think they just have psychiatric problems, when in fact they have these underlying sleep problems. So we did this study. We made the term complex insomnia to describe people that have both a combination of insomnia and sleep disordered breathing. And what you can see on this graphic is that these individuals had an apnea index of 7 per hour. Now, you're probably not familiar with these metrics, so let me just say that if you have 5 per hour breathing events, that's a diagnosis. But that's a mild category. So this group with apneas of 7 per hour would be considered mild. However, when you add in the hypopneas, it's another 10 per hour. So 7 and 10, now our apnea-hypopnea index is 17 events per hour. Is everybody with me? Is that making sense? That's the metric of breathing events per hour. Well, 17 events per hour isn't mild, but it's still only in the moderate category, mild in some cases, depending upon what the symptoms are. Now, when you add the respiratory effort-related arousals, which is yet another name for UARS, in sleep medicine they have this fun creating lots of acronyms. When you add those, you get 24. 24 and 17 gives you 41. So now, when you talk about 41 breathing events per hour, you're talking about somebody having a breathing event every 80 or 90 seconds. That's a severe sleep breathing disorder. And this gives you more accuracy by measuring the 3 breathing events, not the 2. So in sum, of 44 crime victims that were tested, who presented, again, with nightmares and insomnia, didn't present with breathing complaints, 40 of 44 were diagnosed, half with OSA and half with UARS. So at this point, from 2001 forward, we've been trying to put together research that helps us understand how these patients present and why it's so easy both for us sleep doctors and for primary care doctors and other specialists to miss the diagnosis. And I'm going to show you a few studies that we've done that really hit home on this. This first one looks at persistent insomnia in chronic chronic hypnotic users presenting to a sleep medical center. There's 137 adults, 13-year average of insomnia. 80% were never offered any other treatment option. This was the only option. Take this pill for your insomnia. They rated at the time of presentation to us medication efficacy of fair to poor, which means, some years ago, maybe the drug was working well, maybe it stopped working well. The average length of drug use was about 4 years. As you can see from this slide, many of these patients, most of them, have a background of psychiatric disturbances, whether it is symptoms or outright disorders. In this case, it's based on the patient telling us they have been diagnosed with anxiety, depression, PTSD, and so on. So this is clearly a common comorbidity among insomnia patients. Well, what did we find when we put them in the sleep lab? Well, just what we've been talking about already. Their apnea-hypopnea index was 16 events per hour. Their RDI was 41 events. This is almost identical to the crime victim study I just showed you. 70% of them had sleep apnea. Another 13% had UARS. 84% of these people who came to a sleep center, basically in their mind saying something like, well, my pill isn't working, you have another pill. Do you have something else to help me for my insomnia? 84% of them have sleep disordered breathing. And you know from what I've shown you previously, the sleep disordered breathing is very, very likely to be causing these awakenings during the night, for which they have actually used sleeping pills so they could get back to sleep or never even wake up from it. And that should raise the question about respiratory depression if somebody's got a sleep breathing problem. Similar study, again, with treatment-resistant insomniacs. This is 218 adults. Again, nightly prescription use of sedatives, average use of medications 4.5 years. I'm sure you're very familiar with many of these different drugs. Maybe some of you are familiar with all of them, depending upon your practices. Notice that people still were using benzodiazepines for sleep. Some are using non-benzodiazepines, the so-called Z drugs. And then a sizable, another third were using lots of sedating antidepressants or mood stabilizers for their sleep. Again, findings were almost identical. The apnea-hypopnea index was 19 events per hour. The RDI, which includes the UARS component, is 38 breathing events per hour. And again, we had close to 90% of these patients diagnosed with a sleep breathing disorder. And none of those people knew that walking in the door. They all come in with the same, almost identical presentations of, I don't really know what else is going on, but if you have some other ideas, I'm willing to listen. And then a large number just come in saying, what's the next latest, greatest pill? So while all of this research looks really good from the point of view of circumstantial evidence, and certainly I can tell you that if you went to any sleep center and you asked a doctor the question, have you ever treated an insomnia patient with PAP therapy, CPAP, PAP therapy, and they got better, they'll all say, oh yeah, no, we see that. We see people get their insomnia getting better when they use PAP therapy. Nobody had ever done a study on linking this in a scientific way. So I'll give you an anecdote I think you'll find as amusing as I did. I get the opportunity to meet with the world's greatest insomnia researchers. I go to the annual sleep conference. Those researchers are great people. They're all PhDs. They're all neuroscientists. Several years ago, I went up to every one of them at one conference and I said, I've got a question for you. Why do insomnia patients wake up in the middle of the night? I only got 2 answers. The first one was, who cares? Why would we care? Because if you're trained in cognitive behavioral therapy, you know you have the tools to help somebody get back to sleep. You also know you have the tools using something called sleep restriction, where the patient might consolidate their sleep in such a way that they won't wake up. The other thing that came out of their mouths were the ones a little bit more, interested. They go, it's a really interesting question. It's never really been studied. So we decided to study it because nobody's ever looked at why do insomnia patients wake up. This study was prospective assessment of nocturnal awakenings in a case series of treatment-seeking chronic insomnia patients, a pilot study on subjective and objective causes. And naturally, since you already know my bias, that I'm thinking, well, I think a lot of people with insomnia have sleep-disordered breathing, and that's waking up, I better do a really good job of recruiting the right number of patients and the right kind of patients who don't have sleep-disordered breathing. Well, how do I do that? By not allowing people in the study who are sleepy, by not allowing people that are overweight, and by not allowing people that have sleep-breathing symptoms. Surely, if I do that, wink, wink, there shouldn't be anybody in my study who has sleep-disordered breathing. Shouldn't be anybody. So, first of all, and I'll give you some more detail on this because I know this is going to be hard to read. We asked them the question, why do you wake up at night? And if you can see up on this slide, just look at the difference between the black or dark bars or between the white bars. They're coupled to each other. Can you see the black and the white opposite? Well, the white represents a question, hey, tell me why you wake up. And notice how few answers that these people have. Look how much lower the white bars are than the black. The black just means we gave them a list of 20 things and said, do you think some of these things could have caused you to wake up? And then that's when people start firing away. Oh, yeah, stress. I'm sure stress is waking me up. I'm sure I'm uncomfortable. I'm sure I've got a temperature problem in my bedroom. And they go on and on and on. But we didn't do that until after they offered their information, which was very revealing for how unrevealing it was. So more than 50% of people said stress, nocturia, discomfort, temperature, nightmares, thirst, pain, thinking too much, racing mind, anxiety, general worry. So again, you have some degree of combination here of mental and physical factors. And the people are at least attempting to work on this. But when we did these qualitative interviews, you should know that when we finished all of this, before they did their study, half of them said, you know what, I don't really know what wakes me up. And I said, well, how could you? You're asleep at the time. I mean, why would somebody expect you to be able to know that? But thank you for participating on this part of it, the difficult interview. So what did we find? Well, no surprise. Even though these people did not have all these factors like sleepiness, obesity, and breathing symptoms, they had 90% of their awakenings were preceded by an obvious breathing event. Now, by awakening, I'm talking about a 16-second arousal. That's a technical definition that we use in sleep medicine. Many of the awakenings are much longer than 16 seconds. And it averaged out to be 25 awakenings per person in our lab. Normal is thought to be less than 10 per night, and some would say even less than 5 for a normal sleeper. So 90% of these awakenings were caused by an apnea, a hypopnea, or an upper airway resistance breathing event. And again, we got some very good coverage on this, both in science journals and in public media. This again is Dr. Michael Satea, who is also a former president of the American Academy of Sleep Medicine, and Dr. Wilfred Pidgeon, a researcher at Dartmouth. Despite the fact that patients, at Rochester, where my son just went to college, despite the fact that patients with clinical indicators of sleep apnea were excluded from the sample, 90% of awakenings were preceded by respiratory-related events. Most striking, 11 of 20 patients had sleep apnea and 7 more had UARS. At face value, this suggests a sizable prevalence of occult sleep disordered breathing among these patients who had treatment-resistant insomnia. And then these incredibly scientific journals known as the New York Times, Insomnia is linked to trouble breathing. This is interesting. This researcher, Benedict Carey, wrote an article on some of our original work in 2003 and 2004 linking insomnia and sleep disordered breathing in the Los Angeles Times. It was never covered anywhere else again for many, many years. So he wrote about it again in the Times and the Washington Post. Breathing problems may cause insomnia without your realizing it. Okay, so it's clear hopefully from these studies that many more individuals, I'm not going to say it's the largest proportion, I mean, there's no way to know that. Nobody's done that kind of study yet. But if you think about what we saw in primary care, what we saw with people using hypnotics, what we saw at our sleep center, obviously a lot of people who have insomnia have sleep disordered breathing. And nobody is diagnosing it. Nobody is recognizing that the use of respiratory depressant medications could theoretically make the condition worse, although, thank God, the respiratory depressant medication, I mean, the sedatives used now have very little respiratory depressant effects unless you go back to older benzodiazepines. So the question that really should come up is the one about what is the presentation problem here that's being missed? And it's actually fairly simple. And we demonstrated this several years ago by just looking at the way trauma survivors come in for treatment and evaluation. And what we did is we took 89 people who had come through a sleep center. We took 89 people, I'm sorry, who were standard sleep center patients. We took 89 people who had a trauma background. And you can immediately notice the difference in the two columns. The people, let me say once again though, all these people in both columns have sleep apnea. All of them were diagnosed, and they were matched for age. We're just trying to look at their presentations here. So everybody on this slide is a sleep apnea patient. And what did we see? Well, the people who walk in the door, who are the typical sleep center patient, they start talking about, well, somebody saw me stop breathing, or I have loud snoring. But what do these people talk about? They talk about, I have difficulty falling asleep, I have difficulty staying asleep. Almost the identical percentages. The people who have typical presentations of sleep apnea go 60 to 70% with breathing symptoms. The people who walk in the door with insomnia report insomnia in 60 to 70% of the cases, or even nightmares. So that's probably the biggest problem. And others have talked about this as well, that when somebody is speaking about a waking condition, which is they have insomnia, they are sleepless, you hear the frustration and the vexation in their voice, and you want to treat that. You want to help them, and you're thinking, okay, well, maybe a pill will help this, or maybe they need psychotherapy, or maybe they need cognitive behavioral therapy. But you're not naturally gravitating towards, wait a second, why do you wake up? What is the real reason you can't go back to sleep? And so by presenting with insomnia, it clearly steers us away. Again, sleep doctors, primary care doctors, other specialists. Okay, so the last part of my talk, I want to just delve into some presentation pearls for you so you can use this information. And then I'll also talk just a little bit about treatment research, because there's very, very little research on this actual treatment, despite how many sleep doctors have already seen patients respond. So first off, if you eliminated the word snoring from your questions to your patients, you would be far better off. Incredibly misleading term, as you'll see as we go through this. This term, snore loudly, is very reliable. It's good to ask that question. If the person says yes, go to the sleep center, do not pass go, do not collect $200. Absolutely, that patient needs a sleep study if they snore loudly. If they say no, you're in the same place. You don't know if they live alone. You don't know if they're not telling the truth about their snoring. You just don't know. And so it's just not a reliable indicator. We're going to do questions at the end, which should be about 10, 15 minutes. And then choking, gasping, again, very reliable. The problem, of course, is if you're asleep when you have a symptom, that's obviously going to be difficult to get that information from the patient. Therefore, why don't we look for things that occur while awake? And so that's what we do. And we move on here. I would just like to make the point that it is ironic that for doctors who rely exclusively on sleep breathing symptoms, those doctors actually send fewer patients to a sleep center. And they therefore are ending up with a higher rate of false negatives and probably don't know it because they don't understand that unreliability. Okay. So what is the way we do it at our sleep center in general, but also specifically when we're thinking about insomnia patients, because they're much harder to evaluate and make a decision for? Well, first of all, daytime sleepiness and chronic fatigue, not otherwise explained, are really great markers. When you don't sleep well, you're going to be tired and you're going to be sleepy during the day. And that is just a matter-of-fact statement that should never be forgotten, no matter how much you have had experience with, a diabetic, a thyroid patient having symptoms of sleepiness and fatigue. I'm not arguing that. I'm a board-certified internist. I know what we're talking about. But it's still a question of the average patient who walks into a facility today even and started talking about fatigue and sleepiness. One of the first things that's going to go through the physician's mind or the patient's mind or both is, well, maybe you're getting a little bit older. Maybe that's what's going on. Maybe you need to spend some more time in the gym and do something to build up your endurance. It is important to know that aging worsens your breathing. So if you're aging and you're worsening your breathing, now you have worse sleep apnea. And between the ages of 40 and 60 appears to be the time when sleep apnea produces the worst trajectory of change of greater severity. I mentioned chronic nightmares. It's amazing to me. I got started in the field of sleep medicine doing work on nightmare treatment. And just within a few years, we began to see that many nightmare patients had comorbid sleep apnea, really didn't understand it, still don't understand it. But an amazing study was just published or just presented at the sleep conference. A randomized controlled trial showed that CPAP reduced nightmares. Statistically significant reduction in nightmares with CPAP therapy. We've been talking about persistent insomnia. We've been talking about people who are not getting good responses to medication. So this list, very important list to use for evaluating patients, and should raise very, very high suspicions for that condition. Now, thinking about medical and psychiatric comorbidity is another area. I'm sure you all have heard already information about the relationship of sleep apnea and blood pressure. Alcoholism is a big deal because alcoholism damages the upper airway dilator muscles and worsens sleep apnea. Everybody remembers being in an emergency room and seeing somebody snoring very loudly at the beginning of the night and then it wearing off by 6 o'clock in the morning. That's the effect of alcohol doing a respiratory depressant effect and damaging the airway dilator muscles. Substance abuse and chronic pain. We have a lot of CME programs nowadays about the current concerns about opiates. Almost none of them, I know because I went to one just several months ago, almost none of them remark on the relationship between opiates worsening sleep apnea and also opiates triggering central sleep apnea. I'm trying to work with the CDC and Michael Landon at DOH to try to put together a forensic study on this concern about opiate deaths, because it's quite possible that a large number of these people are getting in the prone position at some point after taking whatever the dosage or the overdosage is. They get into bed, they have an apnea, they drop their oxygen, they have an arrhythmia, and they die. So it's something very concerning that's not looked at yet, and that's why we're hoping that we can get a study going. And then two other ones about mental health in particular, that if you're not doing well with an antidepressant, we used to call this the positive effexor sign in 1998, because people would be trying multiple different antidepressants and finally they get on effexor and it still didn't work. He said, well, maybe you have sleep apnea. Maybe somebody's missing the fact that you've got sleep apnea and depression together. And then any poor response to mental health treatment, because remember in the DSMs, they always talk about insomnia or hypersomnia, but mostly insomnia, as an actual criteria for that mental health disorder. Okay, these few are some of the best because it's so easy for you to talk to your patients about these and sell them. And that's exactly what I mean, because if you can sell them on a little pathophysiological link and say, well, if you have this and if you get this treated, this is going to get better, it's quite motivating to patients. And I'll just go through this list fairly quickly. Dry mouth upon awakening. Why do you have a dry mouth when you wake up in the morning if you have sleep apnea? Because you're mouth breathing. Right. You open your mouth. It doesn't work, doesn't fix the problem, but it's a reflex. You open your mouth. So you tell the patient, yeah, this is why you wake up with a dry mouth. Morning headaches. when there is a slight elevation in CO2 caused by worse ventilation with sleep apnea, you end up with the CO2 causing dilation of the cerebral arteries. And so that is the headache, or the sensation that's also called a band around the head. That is eliminated almost in the first time a person uses PAP therapy. So it's an incredible selling point for people who have morning headaches. Chronic sinusitis and rhinitis are very, very common. The theory in general is that sleep apnea produces a friction between the nose and the larynx, and that friction then leads to inflammation along the mucosa and the tissues, actually increasing the risk for rhinitis and for sinusitis. So, the treatment of rhinitis and sinusitis is hand in glove with what we do at a sleep center. We have to have ENT involvement, allergist involvement, a primary care involvement for whatever we have to do. And we're talking about chronic sinus conditions, allergic rhinitis, and a big one that's often overlooked is non-allergic rhinitis, which is a very interesting phenomenon that seems to appear with greater frequency in sleep apnea patients and responds very well to these newer antihistamine nasal sprays such as Astepro or Astelin. One more, and then I'm going to get to the really big one, which is nocturia. Parasomnia refers to sleep talking, sleepwalking, sleep terrors. Other movements refer to restless legs, leg jerks. All of these things we call, they go bump in the night. Well, all of these conditions absolutely are worth evaluating at some point in time. And they clearly can be reported because the patient, their spouse, the bed partner can all report on it. But if you actually look at the data of the people who present to a sleep center with any of these movement complaints, more than 50% of them, well more than 50%, have sleep disordered breathing. When you treat the sleep disordered breathing, all of these complaints go away. The largest number of people who have sleepwalking, sleep talking, sleep terrors have sleep apnea. The largest number of people who present with restless legs, but even more so leg jerks, have sleep disordered breathing. So you don't treat these people right away unless there's a danger of any kind of injury. And then that's a different kind of case, but extremely rare by comparison. You treat them with PAP therapy, and you wait to see if all these movements go away, which they do in more than half the cases. That's when you then reevaluate. So the movement itself, we think, is a sign of somebody trying to catch their breath. They're actually moving their body because they're trying to breathe and they can't breathe. Now the last and the best one, the one that I have been so successful at in trying to sell to patients who don't care about snoring, it's nocturia. And it's really, really amazing. And again, these are very high reliability and they're low visibility in the sense that most people are not thinking about them. What happens when you have increasingly negative intrathoracic pressure when you have obstruction in your airway? Obstruction can be a little bit, it can be a lot, it could be an apnea, it could be a hypopnea, it could be upper airway resistance. But what happens is that increased pressure forces more venous return by either speed or volume into the right atrium. The right atrium has to look at this as an overload signal. You can call it a false fluid overload signal. The patient isn't drinking fluid during the night. The patient's heart, though, is experiencing what appears to be an overload. When the right atrium experiences an overload, it does what? It releases ANP. ANP is what? The body's natural diuretic, atrial natriuretic peptide. So the kidneys then are informed of the need. We have to produce more water to eliminate from the body because we have a fluid overload state. The kidneys do that. It goes to the bladder, and then depending upon the individual's bladder capacity or sensitivities, this issue is just a monster issue when it comes to sleep disordered breathing. We did one study on this several years ago and showed that nocturia is as reliable as the question of snoring for predicting who has sleep disordered breathing. Nocturia is also an incredible marker of your treatment. So if somebody has nocturia after using PAP therapy, one of the first things you would be thinking of is, oh, well, we're not doing a good job here. You ask about prostate bladder issues, drinking too much water at night, diuretics. All of those things are relevant, and all of those things contribute to nocturia. But what I'm trying to get across is that we see so much nocturia resolve after people have used PAP therapy because they're reversing this whole cycle that I have listed up here. And we even see it resolve or reduce in people with prostate disease. So we know that it's a huge impact. And this has been proven in randomized controlled trials, the actual increase in urine output and the decrease following PAP therapy. Okay, now just a few treatments and then we'll be done, because there are very few treatments. It's quite remarkable and perplexing. This is a study we did with 19 crime victims. We gave them cognitive behavioral therapy. And after that, you can see they still have insomnia scores around 13, which is at almost a clinical level. And then we gave them PAP therapy, and they dropped it down to a near cure level below 8. This is a study we did amazingly with nasal dilator strips, just those things the football players wear on their nose. And what we learned was that 75% of people with a likely diagnosis of UARS or mild sleep apnea, 75% reported improvements in their insomnia. And you can see the pink bar going from 16 down to about 10. That's a huge effect just with a nasal dilator strip. So anything about working on the nose is very, very important for insomnia patients. And then this is Dr. Guilleminault, who I was mentored by 20 years ago at Stanford. He did a very interesting study where he started with one group getting cognitive behavioral therapy, one group getting nasal surgery, tonsillectomy or lateral wall pharyngoplasty. Then they would switch, and 3 months later they would get surgery or they would get CBTI. And so eventually they got both. On this big, difficult-to-read slide, we're only going to look at these two. And what you can see is this first one is difficulty going to sleep at night. And what do you see? The white bars represent the people who got CBTI first. The black bars represent surgery. So every time you look at one of these pictures, white always means they got CBTI first, and black means they got surgery first. But you can see at the first follow-up, CBTI, which is a very potent therapy for insomnia, reduced the sleep onset insomnia. Not much change with surgery. And then after surgery, both groups were basically identical. But when you look at sleep maintenance, which is what we talked more about in this talk, you can see that after surgery, the black bar, look how much that drops compared to a good drop with CBTI, but not nearly as effective. And then at 6 months out, it's again equivalent. And Dr. Guilleminault, made a couple of highlights in this that I'll just read to you, that all of these people experienced either sleep onset or sleep maintenance insomnia. At one time or another, they were prescribed hypnotic medications without discussion of the possibility of an associated sleep disorder. And then the presentation of these subjects did not fit the typical profile for SDB. So PAP therapy is a wonderful, wonderful device. I use it every night. I've been using it for more than a decade. Many people think that it's a very difficult thing to use. I would say it's probably easier than signing up for Obamacare. If you really get into it, you will discover that with time, it is something that a large number of patients, even patients with mental health problems, can use it. And then my last slide, I just want to bring to your attention that we generally think about all of this. This whole discussion fits more with a sleep maintenance insomnia problem because you say, well, if that's what wakes you up, let's use this breathing thing to help you stay asleep and you don't wake up. But what about the question of why do you have trouble falling asleep with sleep apnea? And this is where we came up, and I wrote this in my book, Sound Sleep, Sound Mind, that was published in 2007. And we call it the Respiratory Threat Matrix Model of Chronic Insomnia. And what we're talking about here is that you undergo mini suffocations when you have sleep-disordered breathing. So the mind and the body, when they experience these mini suffocations, it is a form of intense mental and physical threat. The question is, do you want this threat to occur? Do you want to feel choking? Do you want to feel suffocations? The most reliable way to not feel the suffocation is to do what? Not sleep. So we believe that racing thoughts are not the cause of insomnia, although they can be in some patients. We think they are the signal or the symptom of the patient who has sleep disordered breathing. And we say this because we work with hundreds of patients who've told us that after starting PAP therapy, their racing thoughts went away. They did not need the medication. They did not need cognitive behavioral therapy. The racing thoughts went away just with PAP therapy. Okay, so PAP therapy is a really good treatment. It's a gold standard treatment. We're trying to normalize the breathing. And in conclusion, I've got a couple other slides, but I'm going to conclude here so we can take questions. There is a cure for insomnia. It is rarely found in a bottle at a pharmacy. There's no question some people can benefit from sleep aids. Over the short term, they can be lifesavers. They can prevent suicide. They can certainly alleviate the insomnia in a depressed patient. So they're a very good thing in the right place, the right time, right circumstances. But they're not a cure, usually, long-term, for the overwhelming majority of patients, as far as we can tell. The cure seems to be coming in a box, sold at a durable medical equipment company. It's called PAP therapy. There are also other treatments, such as dental devices, nasal dilator devices, even surgery of the throat may work. And then we cannot forget that cognitive behavioral therapy is a powerful treatment, and there will be many, many insomnia patients, despite doing well with PAP therapy, that will still need cognitive behavioral therapy for additional support of their insomnia. Okay, I'll stop there. Oh, sure.
How did you diagnose your need for sleep?
I'll get to that in just a second. There are two questions that are actually related that came in for the webinar, and they deal with the phenomena of what do you do in the middle of the night if you do wake up but you're using PAP? Or in a related question would be, how do you deal with the issue of what if your PAP, for example, isn't as good as the more modern PAP therapy devices? So I can just give you a couple of quick facts to answer these questions. Number one, we haven't prescribed CPAP for anybody at our center in 9 years because we don't think CPAP actually works that well in most patients because people have trouble breathing out against CPAP. So we use these other devices that are called bilevel or dual pressures. They're called auto CPAP, they're called auto bilevel, they're called ASV, which is an even fancier auto bilevel device. And so if a person isn't on that kind of device, or if the person doesn't have the right pressures on the machine, then they need to go back to the lab and be retitrated so that somebody can figure out what is wrong with those pressures or what is wrong with that machine. So one of the most common things we do is when we see patients who come to us for second opinions, they're on CPAP, and we say, well, we'll look at you in the lab to see if the CPAP is working. And literally, almost 100% of the time, that CPAP is not doing the job. It's not eliminating the upper airway resistance. It's triggering what's called expiratory pressure intolerance. That is, the patient is fighting it when they're trying to breathe out when the air is coming in. And then the last thing I want to say, so my main point is that advanced technology is out there. The newer masks, the newer machines are much better for most people. It creates much higher compliance rates in patients. And then last, I have to reiterate, if you do wake up at night and you're still having trouble and you don't think it's related to a physiological effect, then cognitive behavioral therapy may be very important for you. And there might be a situation where a person might have to use a sedative at various times to help with that particular problem if nothing else can be discerned. Now we'll take the other questions. Do I have to turn anything off or just leave it all? Okay. All right, your question, sir?
How did you diagnose the need for CPAP yourself?
My story for discovering sleep apnea was that, yes, the question was about my diagnosis for sleep apnea, why I'm using PAP therapy. When I was at Stanford in 1993, Dr. Guilleminault introduced himself to me, and we shook hands, and with his other hand at the time, he grabbed my chin, which had a beard, and he felt around. He said, "It's nice to meet you, Dr. Krako. You have upper airway resistance syndrome." And that was a very interesting introduction, and it was correct, because he knew that when you have a small chin, that's one of the markers of sleep disordered breathing. And I forgot to mention, this is one of the reasons why obesity is a very problematic conceptualization. I don't look too obese. I mean, people have called me a fathead, but I do not look that obese. And that's because the real core of sleep apnea is the airway. It's the craniofacial features. It's what's inside the airway. That degree of crowding is what determines sleep disordered breathing. There's all sorts of research that's been published showing that you get bariatric surgery and you don't cure sleep apnea. You don't even reduce it proportionally the way you expect. Virtually all people who get gastric bypass are going to still end up on PAP therapy at some point within a few years, not just because their sleep apnea got worse again. It just doesn't get as good as people think it does. So what happened was, I being a horrible, horrible patient, because I'm a doctor naturally, it took me 9 years later to actually get on PAP therapy. I started with Dr. Mead, Thomas Mead, if you know him, he's a dentist. He invented one of the dental devices that people still use today, several of them. I used a dental device for 4 years, and I began using PAP therapy in 2002 when I was opening my new sleep center, Maimonides Sleep Arts and Sciences. Because I figured if I was going to open a new sleep center in private practice, I better know and experience what my patients are going through. And that motivated me to go forward with it. And I'm glad that I made the switch because the PAP therapy is much more potent than the dental device. Another question over here?
What about your chin? Because it doesn't look like you have microanapnea, and it doesn't look like you have recess. So what was there about your chin that he felt was creating a problem?
The question was about the size of my chin. I always come to these talks and like to talk about the size of my chin. And the facts are I actually do have a smaller than normal chin. I actually do have a little bit of recess. But there's one particular characteristic of my face that's a dead giveaway if you know about the research that was done in rabbits about 10 years ago. They artificially obstructed the airway of newborn rabbits. Guess how their face grew? Grew like this, vertically. So the airway accommodates. So I'm guessing, based on what my mother has told me over and over again, how much I annoyed her in the first year of life, that I had sleep apnea at that time. And so my facial structure, compared to my older brother, who had his tonsils out when he was less than 2, and who has a square Hollywood-like jaw and face, I have the narrowest face in my family. So that's one of the findings that they learned about sleep disordered breathing and especially UARS. The problem, though, is as you get older, you can have any size face, any type of face. It really depends on how the airway is functioning on the inside that will determine whether or not you have sleep apnea. Other question?
How do you overcome all the problems involved with PAP?
Great question, which sort of begs the question of saying, how do you get over all of the difficulties in using PAP therapy? And I say beg the question because we used to see it that way too, but because of my research background, when we opened up a sleep center, we didn't want to open up an ordinary sleep center. We wanted to cater to people who have mental health problems and sleep problems. And so about 70 to 80% of our patients at any time, any given time, are people with insomnia, anxiety, nightmares, PTSD, depression, claustrophobia, OCD. And that's because that's what my research has been. Even though I'm not a psychiatrist, most of my work was at the university with the Department of Psychiatry doing sleep work. So I was very comfortable with those patients. And we wanted to be able to work with them, and we knew they were going to need to use PAP therapy. So we have developed models with either our own models or in collaboration with a few other sleep centers across the country who recognize that the field of sleep medicine, unfortunately, was promulgated in ways that made it seem like get a sleep study, go to a DME company, get a mask, and then you're done. Everybody understands now that that's wrong. Even Medicare has got into the picture and recognized that doesn't work, and that you really have to have a much more involved coaching model. So as among other things, we invented something called the PAP nap, which is now used across the country in many sleep centers, where the person comes in during the daytime, they don't have any of the wires, they test drive the device, and 90% of the people who test drive PAP therapy suddenly wake up and go, I don't believe it. This isn't anything like what I thought it was going to be like. I'm willing to go forward and try this. The sleep lab is a daunting experience. Learning to use the mask, learning to use all the different little, tools to make the mask fit absolutely requires overcoming the hassle factor. But that doesn't mean you can't do it if you get the right coaching from the sleep techs at my center, or you get the right kinds of tests by the sleep techs at my center, or you have more involved coaching and motivational, interviewing and training of patients by me. So there's a lot you have to put into it, and when you put a lot into it, I'm just amazed at the number of people. I used to think, like all other sleep doctors, once somebody was 60, 65, 70, forget it, they'll never use it. We have people, including my mother, who just turned 94. We have people using PAP therapy 70s, 80s, 90s, and we will work with them, and they can use it. The technology is so different in terms of the devices and the mask. Virtually anybody who is motivated can use PAP therapy. There are some exceptions, and there's always going to be people who can't, but guess what? Most of the people who can't use it, they come back and see us a year or two later, and they try again, and they're often successful because their motivation is so high.